All right, hello. My name is Brian. I'm the instructor out of Baytown. So this is the Modulate review. I have my camera muted because of connectivity issues. All right, we'll go ahead and get started. All right, so mechanism of injury provides a suspicion of injury. It's not an accurate indicator of injury, but you must assess the patient for indicators of injury. Mechanism alone is not grounds to transport to a level 1 trauma center. You have to look at the overall picture. All right. All right. So, vehicle collisions. You should have a high index of suspicion of injury when you have the death of another vehicle occupant. That's super important because if you have a death in the vehicle, then obviously it's pretty serious. There's an mental status, an intrusion over 12-inch from the occupant side. If there's an ejection, all right, and then we don't have access to vehicle telemetry data, so that's irrelevant at this point. Something else to keep in mind when it comes to vehicle collisions is if you notice a car seat in there and there's no patient in there, then always suspect that maybe there's a child that got ejected somewhere. Okay. So another thing when it comes to their vehicle collision and mechanism of injury is that with having the altered mental status and unresponsiveness, it could be an early sign of brain injury. And so they need to get to a trauma center relatively quickly. All right. And then also in regards to collisions, that if you actually strike a fixed object at a high rate of speed, okay, then you run the risk of having significant injury. Mhm. All right. All right. So these are just some summary of injuries that you may have from a vehicle collision. One of the important things to know is seatbelt marks. Okay. If they have seatbelt marks, then that is indicative that the injury is pretty significant. And so they need to actually go to the hospital. Okay. That's important if you got seatbelt marks. Okay. And then right here's a diagram. So you got the vehicle collision where it hits the tree, and then you have the body collision, which hitting the steering wheel, and then you have the organs on the inside that can actually cause additional damage. In your elderly patients, a lot of times they have shrinkage in their brain, and so there's more room for the brain to go back and forth when they're actually in a severe collision. So you got to keep that in mind when it comes to your elderly patients. All right, so you have in a frontal collision, the occupant moves forward at the same speed the vehicle is moving. You can have an up and over pathway, which causes impact to the head, neck, chest, and the abdomen, or of course the down and under pathway, which causes impact to the knees, femurs, hips, and the spine. One thing to keep in mind that if you have a significant femur fracture or a pelvic injury, you can lose up to 1,500 cc's of fluid of blood easily. So it's got to keep that in mind. All right. And then a lot of times when it comes to these collisions, a lot of times the under strain driver, when they strike a fixed object, will most likely have an organ collision. All right. As far as for the rollover, a lot of times specific pattern of injury is impossible. Okay, but you could have multiple systems injury. You could have crush injuries. All right, and then a lot of times they can actually be ejected. All right, let's talk about penetrating trauma. Okay, so some stuff to know: you got the drag, which is factors that slow a bullet down. Okay, so you could have like wind resistance, or maybe a bulletproof vest or thick clothing. Okay, you have the profile, which is the impact point of the bullet. So the greater the size of the impact, the more energy that's actually transferred. Cavitation. Okay. This can be important because it's also called the pathway expansion. So essentially, what it is, you have the kinetic energy from the bullet, and so it extends tissue damage beyond the initial pathway. So if you get shot in the chest or in the abdomen, then there's a pretty good chance, because of cavitation, you could have other organs involved that are injured within that general area. And then you also have the fragmentation, which is where the bullet breaks up into small pieces. All right. And it could cause further injury. Something else to look out for when it comes to gunshot wounds is an entrance wound and an exit wound. Typically, the exit wound is going to be bigger, but your main job is to find how many holes that the patient has in them and then document accordingly. All right, so let's talk about pressure waves. So, from a pressure wave from a blast injury, you have a primary injury, which affects a lot of your pressure injuries. So, your ears, organs, mouth, nose, all of those can actually be affected, and a lot of your hollow organs from the initial blast just because of all the pressure and the force. Okay. And then you have your secondary injury, okay, which is essentially the projectiles that can cause from the bomb or maybe from the explosion that can actually that can actually penetrate you. So you have to watch out for the projectiles and the secondary injuries that actually come with them. Here. And then the third is you have the tertiary injury, which is essentially the blast wind can propel you and you actually strike other objects. Okay, that's the tertiary one. And then, of course, the quaternary one is where you're exposed to ex, uh, chemicals or toxins from the actual structural collapse. So, those are the type of different blast injuries that you actually may come across. Okay. Oh, and then also your middle and inner ears and your sinus areas, okay, can be affected by the primary injury on the blast. All right, so indications for on scene time. So you have what's called the platinum 10 minutes, which what that is that's just a rule to actually try to get the critically injured trauma patient off scene and then get them to a hospital where they can do surgery within what they call the golden hour, which is in 60 minutes. All right. Now, with the Platinum 10 minutes, your main job is to treat all the life threats, get your patient out of there, and then just get to the hospital. All right. Some indications. There's a lot of them, but maybe if you're having a difficult airway, if they're hypoxic or respiratory arrest, if they have a flailed chest, pelvic fracture, pterygium long bone fractures, signs symptoms of severe shock, okay, or if they're seizing, okay, or of course paralysis or suspected brain injury. A lot of those are important indicators that, hey, this is a rapid transport. We need to actually get them to the hospital. Okay. All right. Now let's talk about the different type of bleedings right now. So you got arteries, veins, and capillaries. So when you approach your patient, when you're actually doing your primary assessment, okay, that's when you want to look specifically for the life threats. All right. And then, of course, if you see life threats, then you need to address it. All right. So you're always going to check for the severe bleeding uh, in the assessment. All right. Sorry about that. So you have arterial bleed, which is under pressure, so it's spurting and you got bright red blood. And then you have venous bleed, which is a slow ooze with dark red color. And then you got capillary bleed, which is just a slow, even flow. All right, when it comes to bleeding, and especially falls in general, if your patient's on blood thinners, such as Xarelto, Eliquis, Coumadin, and Plavix, those are the common ones. They need to be evaluated at the hospital. Okay, because if they're on blood thinners, there's a pretty good chance that if they fail, they could have a bleed, but it may not turn up right away. So they need to get checked out. All right. So as far as for nosebleeds, a lot of times it's best just to sit them straight up, pinch their nose at the base of it, and then lean forward. A lot of times you can put an ice pack on it, but you need to keep it shut for at least 10 minutes. All right. And then a lot of ambulance services will carry Afrin, where you can actually squirt that nasal spray in the nose and it helps vasoconstricts everything and then stops the bleed or slow it down. All right. Let's talk about hemorrhagic shock. So, with hemorrhagic shock or signs of internal bleeding, they're going to be anxiety, they're going to be restless, combativeness may be altered, weakness, faintness, or dizziness. They could have thirst, shallow, rapid breathing, rapid 30 pulse, pale, cool, clammy skin, narrow pulse pressure. So, with the narrow pulse pressure, we don't really worry about that too much, but it can be an indicator of early shock with the pulse pressure. All right, so the pulse pressure briefly is the difference between the systolic and the diastolic blood pressure. So, for example, you have a blood pressure of 120 over 80. The difference between that is 40. So, normal pulse pressure is 25% of the systolic BP. So, 25% of the 120 is actually 40, but you want like at least 30. Okay, for that. Because 25% of 120 is 30, but you have 40. Or another example, let's say if you have a pressure of 102 over 88. So 25% of the systolic blood pressure is actually 25. But if you take the difference between the systolic and diastolic, it's 14. Okay, so that's a narrow pulse pressure, and that's bad. So it could be an early indicator of shock. Then, of course, they'll have dilated pupils and then nausea and vomiting. All right, let's talk about the cycles of hemorrhagic shock. So you have trauma, which causes a loss of blood volume from the vascular space, and then ultimately it decreases the cardiac output to allow your major arteries, which in turn decreases the delivery of oxygen and glucose to the cells, which they need oxygen to survive. And then you have those baroreceptors in the brain that trigger the sympathetic nervous system to try to increase the cardiac output, blood pressure, and perfusion because they're bleeding out. Okay. And then, of course, that causes the respiratory rate to increase. Okay. And then they're going to experience tachycardia and then weak peripheral pulses, decreased mental status, and then, of course, clammy skin. And then, if you continue to lose blood, it's going to overwhelm those compensatory mechanisms and then your blood pressure is going to fall. Okay, your pulses are going to become weak or absent, and your mental status deteriorates. And then at that point, your brain becomes ischemic, and then your blood pressure becomes hypotensive. Then eventually, you get brain tissue death, organ failure, and then patient death. So, when it comes to hemorrhagic shock, that is deadly. So, you have to pretty much stop the bleed. Uh, Back in the old days, a lot of times for severe trauma, at the advanced level, they would hang a liter to a fluid. Okay, because the thought process was, hey, they're losing blood. We need to try to get more fluid in there to maintain their blood pressure. Well, what they were finding out with these patients, because everything now is based on science and evidence, is that we were harming our patients because when they go into surgery and they fix the bleed, they're having trouble because you deleted all the clotting factor because all the fluid you pumped in. So now the rule of thumb is, yeah, you're going to start an IV, but you're only going to give enough fluid to maintain a systolic blood pressure of 90 because we don't want to ruin those clotting factors. All right, let's talk about soft tissue injury. So a contusion is a bruise or injury to a tissue and blood vessel contained within the dermis. The black and blue discoloration is called ecchymosis. Okay. And then you can also have a hematoma, which is similar to a contusion, but it usually involves damage to larger blood vessels. And you're going to have a large lump with bluish discoloration. Okay, so it's going to be swelled up. And if you're on blood thinners, it's going to look a whole lot worse. All right. And then you also may have a crush injury, which the crush injury is force great enough to cause injury that's actually been applied to the body. All right. All right. So typically a crush injury isn't good. Okay. All right, because eventually with the crush injury, you could get compartment syndrome. So what happens is, let's say if you have a big 2,000-pound steel beam on someone's leg, it's there for long periods of time. So the pressure and the space in your tissues that are present exceed the pressure needed to perfuse the tissues because your blood supply gets cut off because of the beam on top. It cuts off the blood supply and your cells become hypoxic. And then what happens is it releases chemicals that cause the capillaries to leak and increase swelling. And if that pressure continues, then eventually you're going to have to amputate. A lot of times it could take several hours or more. Treatment for that usually what they call a fasciotomy in the ER, where they just make a long incision to release all that pressure. But it's going to be characterized for compartment syndrome as severe pain, numbness, paralysis, pain with movement. They may have inadequate circulation, and then, of course, their extremities may be hard. So those are typical signs of compartment syndrome from a crush injury. All right. So here we have an abrasion, which is generally caused by a scraping, rubbing, or shearing away from the epidermis, which is the outer layer of the skin. All right, then you could have a laceration, okay, which would be any type of varying depth. And then an avulsion, which is the loose flap of skin and underlying soft tissue that's been torn loose. Okay. All right. Then you may have amputations. All right. The best thing as far as for the amputations is if you have an amputated arm, fingers, or toes, or whatever it is, then you typically want to wrap it in a sterile dressing, put it in a plastic bag, seal it, and then put that on ice. So if you take care of the amputated part, then hopefully they should be able to reattach it. But you never want to put the amputated parts directly on ice. Okay. Crush injuries we talked about. As far as for punctures and penetrations, if you have a gunshot wound to the chest or a stab wound, you need to do an inclusive dressing. With an inclusive dressing, you always want to tape it on 3 sides because the thought process is by taping on 3 sides, when you breathe in, the flap collapses, but when you breathe out, then it opens up to release the air because you want to try to prevent that tension pneumothorax. Now, sometimes you may have an inclusive dressing on, and they may start having increased shortness of breath, anxiety, restlessness, tachycardia. Well, a lot of times you may need to burp it. What they mean by burping it is you just peel open the corner of it and close it, pull it up and open it because you're letting that air escape, kind of like you're burping a baby when you're hitting them on the back. You're just opening up that valve or the corner of it to let the air escape. Okay. All right. So as far as for bleeding, so a dressing covers an open wound. All right, and a bandage secures the dressing in place. So a bandage does not go over the wound, the dressing does, and the bandage goes over the dressing. So by putting direct pressure on the wound, they're trying to inhibit its own clotting factors to stop the bleed. So there's a difference between a dressing and a bandage. All right. A lot of times what you're starting to see is hemostatic agents. All right. This is just an example of a teabag type one. All right, and a common one is Quick Clump that you'll see out there. You can purchase these at Academy, Dick's Sporting Goods, Amazon, and those type places. But basically, how it works is by putting direct pressure over the wound, those granules are in the wound, and so it's clotting, it's working with the body to pretty much clot the wound. And you usually have to hold it for at least 3 minutes at a minimum. You got to make sure all those granules are in there and that it's actually doing its job and give it time to work. Then once it's in there, then you typically don't want to move it. You just leave it in place and then wrap it like normal. All right. So sometimes you may have areas where you can't use an actual tourniquet. So a common one is a cat tourniquet. So the rule of thumb for the cat tourniquet is to go an inch or two above the wound, but not over a joint. And then you actually secure it. So when you're screwing the windlass, all right, you need to tell a patient that's going to hurt worse. All right, because it's not hurting worse than you're doing it wrong. And then once the bleeding stops is when you stop twisting it. And then you put the time on the tourniquet because for the most part, they can still reattach limbs if it's within 2 hours. Now, some of you that's maybe taken one of those stop the bleed courses or one of those trauma combat casualty courses, they tell you use a tourniquet for high and tight. Okay, that works as well, but that's just something that's easy to remember. All right, but the book answer is going to be an inch or two above the injury. Now, junctional control bleeding, they do have what's called a junctional tourniquet, which looks like that. All right, you're typically not going to see that in the field. All right, but they do have them available that they use in the military. So if you don't have one of those junctional tourniquets, then you just use direct pressure, all right, to try to stop the bleed or like those hemostatic agents. All right, so blast injuries, we already talked about that. All right, briefly, the primary wave, okay, creates a pressure wave. With that, and so your gas-containing organs, lungs, stomach, ears, and sinuses are going to be affected. And then, of course, the secondary phase is flying debris. Okay, and then your tertiary, all right, is when you actually, land somewhere if you're thrown. It's typically going to be the same injuries you'll see ejected from a vehicle. And then, of course, the coronary quinary injury, which is the structure collapses, or you got toxins, bacterial, and stuff like that. Okay. All right. So, anatomy of the skin. So, the outermost layer is the epidermis, which is the watertight and resilient barrier. Then the second layer is the dermis, okay, which contains all the sensory structures. And then the innermost layer is called the hypodermis, otherwise known as the subcutaneous layer, which is a lot of the fatty tissue. Your skin is the largest organ of the body. Okay, it protects against water loss, provides temperature regulation, provides a physical barrier. All right, provides sensory perception, also helps elimination of some of the body's waste. All right, so your skin's important. All right, let's talk about burns. So I know you've all heard of first degree, second degree burn, and so forth. So a superficial burn is another term used for a first degree burn. just essentially characterized by redness. It's gonna be a little painful. All right, is your first degree. You're typically not gonna have blisters on a first degree burn. All right, and then your partial thickness burn is your second degree burn, and these are going to be really extremely painful. You are going to have blisters, and they may be white or red. Okay, and then they may be moist. Okay, a lot of people think you want to pop them, but you do not want to pop them. Okay, you just want to just let it be. Right, and then you have your full thickness burn, which is the third degree burn, and that affects all layers of the skin, and that's going to be characterized by black charry stuff. The skin's going to be really hard. Okay, it's going to have a leathery type appearance, but you're typically not going to feel pain. And the reason why is because when it gets to the third layer, all your pain receptors are destroyed, and so you don't have any pain there. Where they have the excruciating pain is usually from the partial thickness burn from before. Now, some cases you may hear what's called a fourth degree burn, and all that does is the burn gets all the way to the bone. But for the most part, we're just going to have like superficial, partial thickness, and then full thickness burns. All right, and this is just affecting the layers. Now, as far as for treatment for burns, okay, you don't want to use any type of burn ointment. All right, you just essentially want to cool them off, and then you want to keep them dry. Okay, so you want to use burn dressings, or if you don't, or sorry, burn sheets. If you don't have any burn sheets, then you just use clean sheets that you get from the stretcher. Because the important thing is you want to actually keep the patient from getting an infection. Infection is what's going to kill that patient on a burn. So you want to try to prevent as much infection as you can. So critical burns. Right, full thickness burns, hands, feet, face, eyes, respiratory burns. Full thickness burns covering 10% of the body surface. Partial thickness burns more than 25%. Partial thickness greater than 20% in kids less than 10. Electrical burns. Anytime you get an electrical burn, they need to be seen because the electricity travels through the body and they may not have noticeable injuries right away. It may come later. Okay, and then of course circumferential burns to any part of the body. All right, the rule of nines. So this is important to know because this is how you're going to actually guesstimate the burns on the body. So you got the head and the neck is 9%. The posterior trunk's 18%, anterior is 18%. Then you have each upper extremity at 9%. Then you got the genitalia, which is 1%, and your hand is actually 1% as well. For the child, all the whole legs are 14%. The entire anterior trunk is 18%. The posterior is 18%. Then you got 9 and 9, and then 18%. So let's say if you have an adult patient, his chest and abdomen are burned. Okay, so that's the whole anterior trachea, so that's 18%. His upper back is burned, so that's 9%. And his upper right bicep is 4.5%. So for an adult patient that has his chest and abdomen burned with his upper back and upper right bicep, his percentage of burn is 32.5% of his body is burned. Right, for a child, let's say the entire right leg is 14%, the upper chest is 9%, and the entire left arm is 9%. And that gives you a percentage that child is burned at 32% of the body. Okay. Now, ideally, they need to go to a burn center. All right, emergency care, we talked about that. Remove from the source. Okay, establish, maintain an airway. Classify the severity of the burn. Cover with the dry still dressing. And then, of course, keep them warm. So when you have your burn, you just essentially wiped out your temperature mechanism with your skin. So you need to keep them warm. So when you're transporting, you need to crank up the heat in the patient compartment because if you're comfortable, patient's not comfortable. If you're not comfortable, then patient's just fine. Kind of like with a newborn baby, you want to keep it warm. All right, so let's talk about ligaments and tendons. All right, so typically a ligament actually connects bones, and then the tendon connects the muscles to the bones, which actually help them move. Okay, so that's the difference between like a ligament and a tendon. Ligament just connects the bones, and then the tendon connects the muscles to the bones, which kind of like helps them move. So that's the difference between the two. All right. All right, so your skeletal system, the axial skeletal system is composed of the head, thorax, and vertebral column. And then the appendicular is made up of the bones in the extremities, which includes the shoulder girdle, and then, of course, the pelvic area. Okay. All right, so you have different type of fractures. An open fracture is a fracture with an associated open wound with it. Okay. So if an open fracture is bleeding, then you need to actually pat around it to stop the bleed. All right. If there's no break in the skin, then it's a closed fracture. Okay. Anything that's painful to the touch and swollen, consider it fractured until proven otherwise. All right. And then you could have a strain, okay, which is an injury to the muscle or muscle and tendon, usually caused by over extension, over stretching. And then you have a sprain, okay, uh, which is an injury to the joint capsule with damage to or tearing of the connective tissue. And then, of course, the dislocations, displacement of the bone from its normal position in a joint. All right. A lot of times it's hard to tell the difference between a strain and a sprain. All right. But the treatment's going to be the same. Just treat it like it's a fracture. All right. Then, of course, we your bone is very vascular. All right. And then we actually talked about that earlier as far as the amount of blood loss. All right. General rules of splitting. Okay. It does not have to be pretty, just as long as it gets the job done. The important thing you want to do is always immobilize the joints above and below the fracture site. And if they can't move it, if they've done that, then you've done your job. Okay. And then, of course, you want to cut off their shoes or socks if it's on their extremities, on their lower extremities, or you want to take off their rings if it's on their hands. All right. Cover all the wounds. All right. And of course, you never want to push the bone back into place. And you always want to splint it in the position found. Okay. Or also the position of function. Okay. That's what you want to do when you actually split it. All right. You always want to check circulation, motor, and sensory beforehand because if you don't and you do a nice, pretty job splitting, and it's like, oh, I can't feel my fingers, is that because of what you did, or is it just because that injury is actually more serious? All right, so check circulation, motor, sensory before and after. You can check their cap refill, or you can actually just check their pulses, have them wiggle their fingers. All right, and then ask them what finger am I touching. But you typically want to put your hand in front of them so they don't see you, then keep it simple. Thumb or the pinky, keep it simple. Okay. And then, of course, if they're showing signs of shock, then you want to treat them for shock. So you lay them flat, cover them with the silver space blanket, give them oxygen, keep them warm, and then haul butt to the hospital. Give them a high flow diesel bolus. All right. So as far as for actual splinting devices, okay. So you got like your traction splint, okay, which there's paramedics that go their whole career with only maybe using traction splint once or twice. Okay. The main reason why is for a traction splint, the indication is for a closed mid shaft fracture. If you have any other injuries to the extremity, such as your hips, knees, lower leg, then that makes the traction splint contraindicating. You cannot use it. Okay. When you put on a traction splint, as soon as you start pulling traction, your patient is going to feel a whole lot better. Okay. You can have a backboard. I think that's called like a vacuum splint. You don't see that very often. And that's another type of vacuum splint. This is what we'll call a Sega traction splint, and this is a hair traction splint. And these are actually just wooden splints that you can actually use. Now, another really great splint is actually called a SAM splint or a formable splint. Those are great for ankle fractures, but they're also great for other fractures as well because they roll up all nice and neat, and they're easy to use because you're basically just conforming it to the fracture site. So it works great as another alternative for splinting. All right, so um, let's talk about head injuries. All right, so you got your parietal bone, frontal bone, temporal bone, all that other fun stuff. Your mandible, which is your jaw, that's actually one of the strongest bones in your body. So if their mandible is broke, then you know that was actually pretty significant. Okay. All right. These are the different layers. You got the cranium, the dura mater, the arachnoid, uh, pia mater, cerebral cortex, cerebellum, the medulla oblongata, and then of course the spinal cord. Okay, those are the different layers of the brain. All right. So some different type of skull fractures. Okay, so a linear skull fracture is one of the most common type, which resembles a line. There's typically no deformity. It's only diagnosed through a radiograph or through an X-ray. So you're typically not going to be able to tell a linear skull fracture in the field. Depressed skull fracture, well, if they got a big indentation in their brain or in their head, then of course that's going to be a depressed skull fracture. Okay, it can cause harm if the bone causes damage to the actual brain tissue. Closed skull fracture is where the skull is fractured, but you don't see any open wounds. And then an open skull fracture is you have an open wound to the scalp. Okay, so having the open wound, you allow a huge possibility of bacteria and contaminants. Okay, we can actually get an infection. So you need to keep that covered up. And then you have the basilar skull fracture, which is a fracture to the floor bottom of the cranium, which actually causes a leakage of cerebral spinal fluid from like the ears, nose, or mouth. Okay. You could have bruising, ecchymosis around the eyes behind the ears. So if you have ecchymosis around the eyes, that's typically called raccoon eyes. And then if you have fluid draining from behind the ear, okay, or from the ear, then those are two signs that you have a basilar skull fracture. And sometimes you may not show symptoms until a couple hours later after the incident. All right. Brain herniation. Okay. So brain herniation is bad. Okay. So the compression of the brain causes it to dysfunction. Okay, which pushes the brain downward, and then it compresses the brain stem, which the brain stem controls a lot of your vegetative and vital organs. Okay, and so by compressing that, then you're destroying the vital functions such as the heartbeat, respirations, blood pressure, and so it is extremely serious, and it is a really critical condition when you have brain herniation. All right. All right. So typically with the brain herniation, you're going to see dilated or sluggish pupils. Okay. They could be actual weak or have paralysis, severe altered level of consciousness. All right. You could have posturing. You have decorticate posturing, which is flexion. So essentially it's to the cords. And then decertebrate is extension, also known as non-purposeful movement. Typically, if you have decorticate posturing, it's going to be an upper level brainstem injury. If it's decertebrate, it's a lower level brainstem injury. So the decertebrate's actually worse than the decorticate because it's affecting the lower level brainstem. And then, of course, you may have diplopia, which is essentially double vision if they are awake. Okay, not necessarily for brain herniation, but maybe for other type of head injuries. Okay, they're going to have an abnormal respiratory pattern, and they also may have Cushing's reflex, which is an increased systolic blood pressure and then a decreased heart rate. So what happens is your systolic blood pressure increases because your body's trying to force blood into the brain to maintain perfusion of the brain cells because they're being compressed. So essentially, the brain's not getting oxygen. And so the blood pressure, the body's telling the blood flow to increase because you want to try to keep that brain perfused. And then what happens is because the brain cells are being compressed, then the baroreceptors kick in and say, hey, this isn't going right. So it causes the heart rate to decrease because the baroreceptors is trying to control the rising blood pressure. All right. And so in response, you'll have like an increase in intracranial pressure. All right. So I may have Cushing's reflex, but they also may have what's called Cheyne-Stokes breathing. Okay, which is just a decreased respiratory effort. Okay, is with Cheyne-Stokes. And then also with Cheyne-Stokes, you're going to have an increased respiratory rate and tidal volume, but you're also going to have decreases bouts of apnea as well. So if you see a patient that's unresponsive and you see that Cheyne-Stokes breathing pattern, then you know that that patient's in pretty bad shape. All right. So different types. So concussion is a mild diffuse injury. Okay, where they may have an altered LOC, but it progressively improves. Okay, may get better by the time you get on scene, or it may deteriorate, but then start to get better when they go to the hospital. Contusion is just swelling of the brain tissue or bruising. Okay, you could have a coup contre coup, where the blow to the head, where the brain is propelled on the opposite side of the skull. Just like we talked about earlier with your elderly patients whose brain is actually smaller, you're in that risk of the coup contre coup injury. All right. Then, of course, you may have a subdural hematoma, which is a collection of blood between the dura mater and the arachnoid layer. It is usually due to venous bleeding. So, for the most part, when you have a subdural hematoma, it's usually going to be a slow bleed. So, they may have symptoms, up to like 3 or 5 days. So, they may have weakness or paralysis, altered LOC, vomiting, dilated pupils, maybe confusion, nausea, vomiting, headache. Okay, so if you have a patient that's having a lot of those symptoms, and when you inquire about your history, well, have you been in a recent trauma? Oh, yeah, well, I fell and hit my head about 3 days ago. Oh, really? Chances are they probably have a subdural bleed. Now, in some cases for subdural hematoma, it could be acute, where those signs and symptoms begin immediately after the injury. The epidural is usually from an arterial rupture, sometimes bleeding. Okay, it's rapid, profuse, and severe. Okay, expands rapidly in small space, which can cause a rise in intracranial pressure. Some signs of an epidural hematoma would be decrease in mental status, lucid interval, meaning that they lose consciousness, but then they become responsive. Severe headache, fixed and dilated pupils, seizures, vomiting, abnormal breathing pattern, posture, and then, of course, Cushing's reflex. All those are signs that they could have a epidural hematoma. All right, so head injury. Your Glasgow Coma scale is the most precise way to determine their mental status, specifically with the head injury. Okay, it's scores given for the eye-opening, verbal, and motor response. So the lowest Glasgow you can have is 3. The highest is 15. So with the eye-opening, you get 4 for spontaneous. If you talk to them and they move, then that's the sound to pressure. Okay, if you call their name, nothing's happening, but you give them a little pressure response and then the eyes open, then that's a 2. Verbal response, if they're able to answer all your questions, they're oriented. Confused, you talk to them, they're not making any sense, but they're talking in full phrases, then they're confused. Words meaning that they're mumbling several different words. And then, of course, sounds when you pinch them, they just kind of make noises. Then, of course, the motor response. So, localizing is where if you pinch his left shoulder, then he naturally grabs his left shoulder. Um, Flexion, we talked about that. And then, of course, extensions. All right. All right. Pediatric head trauma. Okay. So, assessment finds your pediatric patient. They could have like vomiting, increasing blood pressure, bradycardia. Bradycardia in a pediatric trauma patient is ominous sign that they're fixing to die on you. They could be hypoventilating or they could be actual posturing. Little signs for head injuries in a pediatric patient. Now, shaken baby syndrome, you see that sometimes. Shaken baby syndrome is the brain injury that results from the abuse of an infant or toddler when they're shaken forcefully and repeatedly. Some risk factors is young parents or maybe single parents, stress, domestic violence, or even alcohol or substance abuse, unstable family situation, depression, unrealistic expectation, or maybe the history of the parent or caregiver being abused as a child. You're not going to ask if they were abused as a child. Okay, you're not going to accuse the family of anything. You just basically look at your surroundings and see what you find. They could be extremely irritable. It could have altered mental status, poor eating or feeding. So you need to ask them, have they been eating and drinking okay? How many diapers have they changed? Vomiting, and then, of course, weakness. All right. Could be respiratory distress and seizures. Uh, they're having trouble staying awake, or you may have bruising to the face. The treatment for that, control the bleed, take spinal motion precautions if needed. Elevate the head to 30 degrees. You also do that with the adult patients because by elevating at 30 degrees, then you're leaving the pressure on the brain, airway breathing, then of course circulation. Be prepared to provide emergency care for seizures. Then always monitor the patient because they can deteriorate in a heartbeat. And then of course taking them to a pediatric trauma center. All right, that's pretty much all I got. I appreciate you actually listening to this. All right, I appreciate you actually listening to this, and I wish you guys the best of luck on y'all's exam, and good luck to y'all. If you have any questions, get with your lead instructor, and then they'll definitely help you out. Thank y'all for y'all's time, and good luck.